I'm delighted to be here. How many of you were here in 2015? 1, 2, 3, 4. 3 or 4 others. How many have heard me lecture at some other forum? Quite a few. I'm delighted to be back. Very pleased to be here. I had a physician who, at that time, we did not know that Cipro and Levo dissolved tendons. That was 2009. When I was here in 2015, I think I'd just gone on the cane, but I was walking very well, thank you. 2019, I'm still on the cane. I'm not walking as well because the shredded tendons begin to pull away from your bone. And I have no connection between the upper and lower part of both knees, both hips, and both arms. I'm a great proponent of physical therapy. If without physical therapy, I would not be walking or standing at all. If I have to sit during the lecture, I will do so. I will try to stand. I wanted to cry. We all want to cry. Gav was a very close friend. We'd worked interactively for many, many years together. And sometimes life isn't quite fair. And Gav lost his wife way prematurely as well. So I am scientific chairman and local committee chairman of a meeting I'll invite you all to. And you may think it's too basic science, but we're going to honor Gav Pasternak at the International Narcotic Research Conference, which is a very basic scientific conference to be held in New York City, July 7 to 11 at the Hyatt on 42nd Street. And actually, we have Dr. Pan, who will be honoring Gav. We lost 2 leaders in the field. The other's a German, Albert Hertz, was lost this year, and he shall also be honored at that meeting. As you've heard, I work primarily in addiction. I am going to ask, with the slight schedule switch, how much time do I have? I have an hour, okay. Well, thank you for telling me. I'm terrible on time, as you know, but that's okay. But at least I know. What is addiction? Well, addiction is compulsive drug seeking and drug taking despite negative consequences to self and others. And it is something that most of you have seen. How many of you are aware that you have seen addictive disease? Yeah, I would think that's about right. And I compliment you for recognizing the disease of addiction. Unfortunately, there's a yin and yang in pain management. We're knowing more and more about it. Pain is not addiction. Addiction does have pain with it. The management of each is quite possible, but one needs to know how to manage it. What's the natural history of drug and alcohol addiction? Well, first there's an introduction to the drug. And this is the one place that I'm going to say something even more boldly than I said it 4 years ago. Pain needs to be managed, but when you manage pain, you are unaware of who is going to be vulnerable to develop an addictive disease. And this is something we can do nothing about yet. And I frankly don't see in the very near future, even with biased agonists coming along, us being able to do anything very soon. My lab, which has been working for so many years on this problem, and many other labs internationally, are beginning to see that addiction is a grid between use of an opiate, which may be totally justified, but use and then genetic vulnerability to develop addictive diseases. It's not your mother. It's not your early upbringing. It's not many other things that for years many people thought were very important for developing addiction. Decreasingly do we think that. Science shows that there's vulnerable people and over 200 genes with SNPs, which have been associated with opiate addiction, have been found, and over half of those have been replicated. So this is a major thrust of one half of my lab at this time, and the story's still coming in. It's a good story, it's a bad story. Most people do not have the vulnerability to develop an addiction. And we can manage pain beautifully with opiates, and we need to know when to start them, but also, more importantly, when to stop them. And we may be able to protect people who have the vulnerability to develop an addiction by stopping the pain medication rapidly enough. So this diagram simply gives the flow from first use to then repeated use, self-administration, which is different than physician or nurse practitioner administration, and then going on to develop an addictive disease. This is true for opiate addiction, is true for cocaine addiction, is true from alcohol addiction. And my lab finally, which I wasn't doing 4 years ago, we finally realizing that here in Massachusetts, California, Oregon, and Washington, you've legalized marijuana, and marijuana is not a great thing. We see addiction to marijuana, and we now have launched a portfolio both at the bench and clinical work. So next time you hear me, you may hear me talk about marijuana addiction. How many people in U.S. are addicted to opiates? Well, we have about 500,000 to 1 million that are heroin addicted. It's probably greater than that. But I think the striking number to take from this slide is that 14% of the population of U.S. over age 12 have self-administered an opiate illegally. Where did they get it? Medicine cabinets. That's the way it starts in most kids these days. So what do we need to do? Have less opiate in medicine cabinets. And that's really a critical message, a take-home message that you're going to see me put more and more into. We know that roughly 1 in 5 to 1 in 15 persons who ever self-administer an opiate will become opiate addicted. This is not pain management. This is self-administration, oxycodone, Vicodin, whatever. 1 in 5 to 1 in 15. It depends how you like to gamble. I don't. And to me, that's a very high percentage that will go on to become addicted. So from last summer to the New York Times showing us a very dramatic increase in overdose deaths. And this was of great concern. And the overdose deaths are increasingly involved with not only heroin, but especially heroin laced with fentanyl. And fentanyl is turning out to be our most lethal opiate. Very few, even physicians, know how to use fentanyl correctly. I think it should be sparingly used. My own recommendation, it be limited to hospital use for perioperative use. We have other very good opiates and non-opiates for outpatient use and general use. But the fentanyl derivatives, there's many of them, are just uniformly extraordinarily potent. We still have people dying of plain old heroin, but you have to have a huge amount of heroin. In New York, people want to avoid going to dealers where they know people who died after getting heroin from that dealer. They don't want fentanyl. But I learned to my total amazement when I had a guest recently from Ohio that in Ohio they actually seek out dealers that have had people that are known to have died because people think the heroin must be better, stronger. I find this so remarkable. I just wish to share it because I find it so odd. Now, I'm not going to spend much time on this, but I have 6 policy slides, and these have been broadly shared with people in high places, both in my state and in Washington. And I have distilled it down, but I think very strongly we have to come down on this getting rid of too many opiates being on people's medicine cabinets and realize that for acute pain, I don't know what you've been told the last 2 days, but for acute pain, you need to use opiates usually for only 1 to 3 days, no longer than that. And you essentially never need to use it for more than 7 days. The one indication for chronic use of opiates is cancer pain with bone metastases. My husband died since I last met you. He had lung cancer, but he was blessed in that he never had bone metastases, so he did not require pain management. And having known and worked with Gav so long, who worked at Memorial Cancer Hospital all of his career, I was very grateful for that, but opiates are very effective for cancer pain. They are not effective for most other kinds of pain, although they have some effectiveness for a few types of neuropathic pain. We need to really teach this in medical schools, nursing schools, other education. We also need to have CME on it. And I'm delighted that after this meeting, remember at this meeting 4 years ago, the luncheon speaker was your new governor. Yes. And Charlie Baker, you invited me to have, you, the leaders of this meeting, invited me to have a dialogue with Charlie Baker. We became very close friends. And in that dialogue, he said, Dr. Kreek, what should I do? He had talked elegantly about fear that his son might become addicted, having been given opiates for elbow problem that he'd had in the sports at college. And I said, we need to do three things. Number one, we need to decrease the amount of prescribing of opiates. Like your son was given a week, you told him to use 2 pills. That was correct. And we need to have more access to treatment of addiction for those who are addicted. And I pointed down the street and I said, Harvard doesn't have a curriculum yet. They're the first school in the nation that now has a curriculum in their medical school, 4 hours. Very, very important curriculum founded for that. And I said, finally, and also Baker put into the state mandate for getting relicensed in Massachusetts, you have to take a course in addiction. Well, this is true now in 15 states, which is fabulous. And it's going to be going higher and higher, I assume. The final thing I said, we need to get rid of stigma. Persons with addiction have a disease, and it's a disease just as serious, important, to diagnose and treat as any other disease. Now, I'm not going to spend a lot of time on this, but I've said most of what's on this slide, so I think we'll simply say, don't prescribe too much, and be sure that a person really needs more pain and has not passed between needing pain for some transient problem into the area of addictive disease. Overdose. You're seeing more and more here. It's actually going down this past year in Massachusetts, but it went way up with the fentanyl crisis. We need to realize that naloxone is the single most effective compound to treat overdose, threatened overdose. And I'm sure you in Massachusetts, like we in New York, have saved thousands of lives by having naloxone in the pocketbook, in the back pocket, and in every first responder.